Just going to go on the 5 first.
Full 5 for entry.
All right. Good evening, everybody, and welcome to New York. Welcome back to Mount Sinai on this Wednesday, the 3rd of May. We have a wonderful live case here that we're prepping up here as we speak. Again, I want to congratulate the team and Dr. Mehta for all the hard work that he's doing to make this happen. It's been a phenomenal success in just its second week already. I think we can declare it a success. Mag up, please. Yep, mag up. And so as you can see, we have a great live case. So without further ado here, I'm going to go ahead and turn it over to let me introduce my team. To my right, we have Dr. Raman Sharma, who's our Associate Director of Endovascular Intervention here at Mount Sinai. To his right, we have Ray Lascano, who's our interventional nurse practitioner. Lock it. Yep, perfect. Thank you. To his right is Osman Jaffer, who is our current endovascular fellow. Our nurse is Elizabeth, and we have Habib as our tech. So we have this wonderful live case, very complex, as you can see. I'm just getting the sheet up and over that we're going to discuss you shortly. So I am going to turn it over to our endovascular fellow, Dr. Osman Jaffer.
With non-healing left toe wound, dorsal aspect category 5. ABI showed right 0.3 and 0.22. His meds are as above. He has a Doppler AT on a dorsalis pedis on the left side. Creatinine is 1.4 and the hemoglobin is 13. This is his runoff diagnostic from a diagnostic angiogram we have here. Get running over here. Severely calcified vessels. You can see in the mid SFA, there's a 70-80% lesion, and then right there in the P2 segment of the pop, you have a CTO going all the way down with really one vessel runoff to the foot. The AT
opening pressure, guys.
That point over there, you can see right here in our DSA. Can you go back to those? Yeah.
So while they prep up the slides, so we have a patient. Oh, there you go. Thank you. I think we may have some technological issues here, so we might have to do our pictures today. Oh, there you go.
Yep.
So you can see that you have a one vessel runoff, which looks like possibly the perineal of the AT. So since the diagnostic was done, what we decided to do was not take further pictures and do everything live for you. So what we've done is a creatinine, but I want you to look at the arch. It's a very, very narrow arch over here on coronary. It's a very, very narrow arch, and I just want to talk a little bit about the technique that you may face and the difficulties you may face. So what down, and so what we decided to do at this stage is just to go ahead and first put a stiff glide wire down, and then we tried to track a 7 French sheath over the glide. That wasn't possible. So at this stage, we said, you know what, let's put a 5 French 45, which went very slowly, even that I had to telescope it over the arch. And then Dr. Sharma and I switched out for a what we call as a super core wire, which is a super stiff wire. And then we put the 7 French over that. Now we're just going to do the diagnostics, and I'm going to do limited diagnostics because of our creatinine, which we want to be very, very cognizant of. So Dr. Sharma is going to go to low mag here. And what we're going to do is we're going to go ahead and try to take these pictures on the left coronary settings. So this way we reduce our dye going forward. But again, at the same time, it's almost like the same thing. If you decide to do it, you have to do it right. So we will take, my DSA guys?
No.
So we will do proper pictures. Yeah, please. I'm just going to do very minimal pictures. So obviously you can do a regular cine runoff or DSA. I'm just going to do very little bit of, just a little bit of contrast here just to see, I guess, that was all flush. So in this one, there's your contrast. You can see he has diffuse SFA with a focal, probably 60 to 70% narrowing, but in a patient with an ulcer, obviously it's something you want to take seriously. Now, as we come down to the mid-distal SFA, We're going to take another picture here again with just a little bit of contrast, maybe 3 cc's or so, just to see the lesion. Here again, you can see there's a occluded top right there with all the collaterals coming off, all these bridging collaterals, which is going to make it quite a difficult case to do, especially in the CLTI patient. So now what we're going to do is we're going to go a little bit to lay out the AC and the PT. You'd like to go to a LAO configuration, and the rule we follow most of us is that below the knee is lateral LAO 20 or 30, above the knee is contralateral, above the LAO 20 is contralateral. So you can see we want to see the bifurcation well. So you can see he has very, very poor flow here. He basically has really no discernible flow below the knee. And then what we're going to do is we're going to go down a little bit lower. Discernible flow below the knee. This is the kind of the shot here. We're going to go down a little bit really want to see. We need to pull him up again, guys. I mean, so we're going to adjust him in a second. We really want to see. What we're going to do is just take a picture because we have to see the foot. Just to show you how the foot looks. What we're going to do is just see what's the vessel. We have to see the foot to show you how the foot looks and see what's the vessels you can do. Not right now. So you can see there's a vessel that comes back. I can't come down any further at this stage because of the assist. So we're going to have to pull our patient up, which we just did. So that's excellent for us. At least we can see a little bit more. So hopefully we can try to go a little bit. I mean, can you pull them up a little more, guys? Well, there you go. Okay, now I can maybe a little bit more. That's it. That's perfect, Liz. Thank you. We have an incredible nurse here, Raman and I, so we're able to do this.
Super strong.
Super strong. She's pulled, and you can see here as you take the picture, you have a single vessel runoff by a robust, what looks like a dorsalis pedis to the foot. So now our anticoagulation strategy is Angiomax. And what we're going to do is Raman and I are just going to talk a little bit about our strategy. And we've come up with a good strategy here to go ahead and do this. And I want to talk a little bit on angiographically what we're going to do. So we're going to go back here. Sorry. So I want to show the SFA. So again, he's a Rutherford 5 patient. He's got a small ulcer, not a large ulcer, but you do need to get some sort of direct line flow, straight line flow to the foot. You can see he has a short segment a popliteal occlusion that's quite complex.
Yeah.
And then he has a mid SFA lesion that's 70%, but just opening that is not going to heal the lesion. So I think Raman would agree with me, and I will just talk a little bit about the technique here. We would definitely start with dual access here, with a catheter down below, because I think when you look at the trifurcation, you really can't see the ostium of the AT. So here's a trifurcation. You see there's a large collateral, there's the popliteal comes down, and I don't see a good ostium for the anterior tibial for us to get into. So having, go ahead, Rum. But
it actually almost looks like the AT has an anomalous origin. Even
it could be part of the perineal.
Exactly.
But I think that's why coming from below with a wire is going to help you a lot. And I'm going to have Raman now demonstrate pedal access for you with an ultrasound. So this is a very, very important skill. I'm just going to lower the table. I'm going to let him go ahead and do his work as I talk to you, and he'll talk to you as he goes through it. So for those of you at home, in the past, before we were doing retrograde access via the pedal, we were actually just going ahead and just trying from above, or maybe having to go antegrade.
Yeah.
But the algorithm of adding pedal access has really changed our ability to be able to go ahead and take on these challenging lesions. So we've chosen to choose. You could say, well, it's counterintuitive to choose the only vessel that's healthy in the foot. But the idea is that we're not going to put a sheath in. We're just going to get access. You're going to see Dr. Sharma's
going to use
a ultrasound to really show how to get into this vessel, and then we're going to show you our techniques. So Ramanji, can you talk to them a little bit about how we're doing this and what our techniques are?
Yeah, I mean, so it's very similar to any other radiographic, ultrasound guided access. The only difference is that, again, this is the challenge here is that you're accessing, as Dr. Krishnan was saying, you're accessing the only vessel that's going to the foot. So doing it with ultrasound guidance is probably the best way. There are some people who really advocate.
Ultrasound to the audience, guys?
No, it's okay. Really advocate for more of a
ultrasound is.
I'm sorry,
I can't see it.
Okay, you need to plug in the ultrasound now. I mean, you have to plug in the ultrasound. Okay, I'm sorry, you have to. I mean, I don't understand why you guys didn't tell me that before we started. Okay, so anyway, talk through it since they can't see it.
Yeah.
We'll do it.
So there's a lot of people who advocate for a radiographic guided, but I think this in today's day and age where you usually have ultrasound so readily available, can we actually turn the ultrasound on so I can see something?
So just to, while Raman turns the
Yeah.
ultrasound on, but it's imperative that you actually are able to see this properly. And unfortunately, we're not going to be able to see it today. But you need to identify the veins, and he'll talk about it. But to build on his point, we were actually doing this all under angiographic guided access. And as as Dr. Sharma was pointing out, it's not the most optimal way of doing it because the ultrasound gives you such a good guidance to be able to see it. So we're going to turn this ultrasound machine on if we can. If we can't, we'll show you the old-fashioned way. That's all.
Yeah.
But
again, the main the main teaching points, obviously try to go above the ankle. You don't want to go too low. The one of the main issues that you also have to consider here is that as you are doing obtaining your access, make sure you have a similar radial cocktail that is also ready.
There you
Very
go.
good, thank you. A good radial cocktail that is also ready. Now, we can't see this, correct?
No, they can't see. You have to talk through.
All right. So basically, so what you're looking for is see the artery is usually very well defined. He has some more calcium, has some more of a pulsation as well that we're seeing here. And you see it usually flanked very nicely. If you could see it, you can imagine, a big vessel in the middle with two smaller veins on the side. If you compress, with pretty gentle pressure, remember this is a CLI patient, so even more than regular pressure will compress all three. So the key is to kind of use just a little bit of pressure, enough to collapse two of the veins, which you'll see will not collapse the artery. Plus, you have a few other tricks here that when you see that there's some fibrocalcification around the artery, you don't typically see those around the veins. And with that, you'll then be able to identify this. And again, one of the keys is try to go a little bit above the ankle. You don't want to go too low. You don't want to go too high. And the key is also just try to make sure that wherever you do choose to access, it's a good place for you to also achieve hemostasis afterwards. To begin with, just a little bit of lidocaine on the skin, a little pinch.
So while Raman is giving the lidocaine, I just want to talk a little bit about the access, the level. You want to have it in a compressible zone in case you don't cross. So if you keep it at the lower level where the tibia, where the anterior tibia runs up and forward to the tibia, you can actually compress it against that. So the other thing is that you're not able to see is that you have daughter veins or sister veins. So the artery's in the middle with the two sister veins on either side. So because of that, when Dr. Sharma is compressing it, he will compress with mild compression. He'll be able to compress both the veins, but not the artery. So don't be fooled by that if you can't compress the artery, that it's not the artery. So right now he's entering it with the needle, and again, you'd like to get a anterior wall stick. Even with the best of hands like Dr. Sharma's and other hands, you may get into the vein, but that's okay. I mean, you can always pull out, put the wire in, leave it there as a target, and get into the artery, because this veins run side by side, parallel to the artery. So therefore, it's very, very important. So what? And the other thing also that you're not able to see is that you actually want to see the needle actually enter the vessel if you can. So can you please? We don't have power Doppler on this, do we?
No.
So yeah, so that's the wrong machine. So we don't have power Doppler. So if we had power Doppler, we'd be able to see the needle actually enter into the vessel, which would be very, very good for us to show you. But at this stage, what we're going to do is he's going to try to he's just trying to focus the needle on top of the artery, and then once he's in, he'll get flow back, and then once the flow comes back, we'll take the stiff wire. So why don't you leave that? We'll go on fluoro now, just to show them how the wire goes fluoro.
Okay.
So I'm just going to move the sorry, Roman.
That's all.
Fluoro again. Yep. So you can see it. There you go. So there's the needle, right? And now he's going to go ahead and just thread the wire. This part you should always do it under fluoro. So fluoroscopy is going to help you because it may still be in the posterior wall, and there goes the wire. I believe, yep, straight up, okay, and no resistance whatsoever. So at this stage, we're going to stop, and I just want to demonstrate we're just going to leave that in while he's going to let it bleed out, and it's okay to let it bleed. It's not very vivacious bleeding. Watch your knees, please. And what we're going to do is I'm just going to go lateral here. And hold on a second, please. So what we're going to do is we're just going to confirm the position before we go ahead and do our dilator, which we can let go now. Just I'm going to irradiate you. Yep. So we're just going to inject here. And we're just going to make sure, because as good as you are, you may be in the artery. It's always good to confirm that you're in the vein. And since it's a live case demonstration, we'll confirm that we're in the artery here. And you can see as the blood comes, we are perfectly in the artery. So at this stage, what our system here is to put a dilator, don't put the catheter, and don't put a sheath. So we're using a micropuncture stiff dilator to go in that Dr. Jaffer is giving to Dr. Sharma. We're going to put this in, and then we're going to give a radial cocktail. Exactly what Dr. Sharma described earlier. It could be obviously in different institutions, in different places. It could be different things. So once it's in, you don't have to go all the way to the occlusion. You just go ahead, pull this out. And then now at this stage, we're going to go ahead and work from below with a wire.
All right.
So what I'm going to do is now as he's giving the cocktail, I want you guys to always take a picture from below with a little bit of dye, because you may find a lot of hibernating vessels that didn't fill. The concept of hibernation is very, very important. So it looks like it's occluded here, but we'll take a quick picture, maybe pull it back a little bit.
Yeah.
We'll take a quick picture here and we'll show you exactly how this looks here. So here's the, now Cindy now,
This is dying.
we'll do a quick
Oh, this was flush.
Saline, yeah,
Oh,
flush.
Okay, that's flush, that's why.
No
So we'll
wonder.
do a quick little light cine here of the lesion. And you can see, so it is a true occlusion all the way up. So at least we have this. So at this stage, I'm going to ask for a hydrophilic wire. Give us a command wire, guys. Yep, you can let it bleed. Let me see.
Yeah, looks good.
Give us a command wire.
Yeah.
And give me the towel. So we're going to go with so Raman, maybe you can talk about our wire algorithm here, how we do things, so on and so forth in terms of our wire choices.
Yeah. So again, as Dr. Gershon was saying, hydrophilic wire up front is usually the best starting point here, because we do see that there's a lot of hibernating vessels where it may seem like a total occlusion, but since there's such poor antegrade flow, and there is some disease of the tibia vessel themselves, you may be surprised to know that when you take a hydrophilic tip wire, typically an 014, 018 system, definitely not 035, as you take your wire up, you may just happen to glide into these vessels that are otherwise seemingly closed. We're seeing making much more progress than what we would have expected.
Okay.
Now, typically with the glide wire on, as the dilator comes out,
yeah, look, this is a stiff note, bro. Flora.
The dilator comes out, we will go with also a transit catheter. We have here is a 018 Trailblazer.
It'll go. Should go. Actually, you know what? Why don't you get a? Do we have an 014 teleport? Give us a teleport here. So you can choose an 018 or 014. With the progress that we've been able to make, I'm going to go with a teleport. Can we grab a teleport, guys? Yeah, so we're going to grab an 014 teleport. We could try with the 018, but I don't think it'll track.
Yeah.
I don't think it's going to track.
So it's always, yeah, sorry, go ahead.
No, go ahead. Keep talking.
It's just so again, it's you should choose the transit catheters that are in conjunction with what the wire base you already have inside, and then kind of like what you're feeling. You know, Dr. Gershon was pushing this wire up, felt that there was some degree of resistance, so that's why the shift went from the 018 transit catheter to the 014. Teleport is typically the one that we typically go with when we're working on an 014 system. A Navicross or a Trailblazer or a CXI catheter do quite well from the 018 standpoint. And as the dilator comes out, we load this on and we see how much distance we can really get with this.
I want you to look at how much purchase the wire is made in a relatively quote unquote occluded vessel. This is one of the things we see more and more of, this hibernation that I talked about. And we actually have a lower threshold of getting pedal access. The difference is we don't put sheets in the pedal because we feel that the sheets are something that can actually disrupt the vessel, even though the slender sheets are fantastic. I think in this particular case, but in this particular case, I think that it may not be the right thing to do. So we're going to go ahead and we're going to try to enter this. It's a very soft wire. I'm a little concerned.
Yeah. Taking the transit catheter through the skin
dry gauze
without a sheath is usually quite challenging. The combination of a dry gauze in the hand and lubricating the actual access site usually kind of helps
down below, bro.
Slowly make it get through the skin. Because remember, at this point, we don't have any dilator.
Oh, good. It made it.
Yeah.
Okay, good. So now I'm just going to take it up as Dr. Jaffer gives me a rail. And then I'm going to let Raman just wire it because he's closer to the wire.
See where it
so
goes.
I'm just going to take it as far up. And this is when what I want to just stop here for a second before Raman wires it. what I want to do now is leave it there. I want to actually come from above with a wire. So Ray, give me a command wire from above. So what this is going to allow us to do,
035, sorry.
what this is going to allow us to do is give a target for both of us to be able to work. So a lot of times, we just go without a wire, but Dr. Sharma very follows discipline very well, and I don't, as you can see. So Dr. Sharma will put a wire down for us. There you go. And I'm just going to take this catheter down, and you can see here we're just going to get to the point of occlusion. And then what I'm going to do is I'm going to try, because I might be able to get this wire down further from above. So we've got a anticoagulation with Angiomax. We've got our 014 wire from above, from below, and now we're coming with an 014 from above with I just need a shape maker. The one thing I want you guys to be careful about at home is that please don't switch by mistake, pull the catheter out, because you have so much equipment on the table, so on and so forth. So, be very cognizant, because these wires can easily slip out. And when they slip out, it can really become a problem. So the reason I'm doing this is I really believe that we're going to cross this from below. We've been surprised before, but I think from below is going to make it easier. And what I'm going to do is just give, either one of us a target. Mag it up, please, for me. Give either one of us a target so that we can get down there. So I'm just going to go take this 014 wire down. And that's the collateral, as we talked about, right? So there we go. That's probably the occluded vessel. So I'm going to take this down as far as I can. And then I'm going to go a little bit maybe toward me with the II. Yep. And mag it up nicely for me. And then now what I'm going to do is, because of his creatinine, I'm going to inject through this catheter rather than from above. Rather than give 10 cc's, I'm going to give 2 cc's. And now you can see Dr. Sharma's wire is down below. So so now he has a target, I have a target. We're just going to do a quick DSA here.
Yep.
So DSA, yep. And we know it's a small segment occluded from here, and there's our little stump, right? So what I'm going to do is Flora again. So I'm just going to, Flora, please.
I'm just going to put this on the frame. Good.
So I'm just going to try to go into that and just inject. So that's not it. So I'm just going to try to find my stump here.
Yeah.
That may be it.
So this is again,
that looks like it.
This
Now
is again a technique
the other one is roadmap. So that's just to get into that. Now Dr. Sharma has a roadmap from below. I have a roadmap from here. Now the thing is, we don't know if this is a high takeoff AT. We don't know anything. See that takeoff of the vessel circling around, which we thought was a collateral. That might be the AT.
High AT.
That might be the AT. So that's one of the other reasons we need to go from above and below. So I'm not even going to bother here, because recanalizing this below is going to complicate everything. So I'd rather have Dr. Sharma cross from below into this high takeoff AT. So well, before we do that, okay, let's see how this wire goes. You're right.
Now this is going to be an interesting thing here. If this is truly the high AT here, all that distal vessel, we're not going to be able to, we're not going to be actually.
So I'm just trying to take this down, get him a little closer. It might be. So let me come off roadmap here just so we can see what's happening a little below, Flora. Okay. So I just want to I'd like to get my teleport as close as possible so we can cross this. So there goes the teleport, right? And if I was a betting man, I'd probably say this is the high takeoff AT, but we'll see. I don't believe in gambling, but we'll see. Okay. So let's just give you a target, Roman. So we'll give him a target. Roadmap, guys, from above. Ready, Flora?
Yeah.
Mm-hmm. Okay. So remember, that's an occluded vessel, so we may be totally wrong. Let's see. Let's see where it goes. Flora? Mm-hmm. Yeah, that don't look like it. We pull back down here.
Yeah, I'm not a fan of how that turn is going.
Yeah.
So we're kind of committed to that side.
So in the meantime, come off roadmap here. Let me work from above to see what it takes us. Can I have a Flora, please? Yep. I'm just going to pull this back. Give me a wire from above now. So Roman, can you talk about some of our wire choices while I work from above? Give me a Confianza, Habibi.
So as we begin the escalation process, we always begin with the hydrophilic wire, as we did from below. with this case, we went with a command wire, 014. You can also do the command 18. They'll give you some more support. Typically, when I do pedal access, I actually usually start with the V18 wire because there's just so much support in the body. But that's assuming if I go up front with the 018 approach. Now, once you've kind of exhausted that, if the wire tip moving the way it is right now from below, you've kind of already established, for a fact that this is now a totally occluded vessel, that a hydrophilic wire is not going to be, getting you where you need to go. It's not going to be able to get you where you need to go. So then we begin our escalation towards the CTO wires.
Mag it up, bro.
We usually begin with a Confianza. Again, it's important to remember your working length. So for those who work in a coronary lab, remember you need the 300 plus wires. So all your Gaias are not going to be long enough, but it's a Confianza. Typically, there's a first wire that we usually go with. Following that, depending on the progress you make,
remove the ultrasound.
going to Statos. Again, the 20s, 30s. At that point, it's kind of a case by case basis, because what happens is that as we continue to use these CTO wires and continue to make progress, you're creating small dissection planes. So it's not uncommon to actually then go backwards to another hydrophilic wire, because as you've made so much progress with the CTO wire, even if you've not gotten into the vessel or you're just dissecting around it, you're creating planes. So it's not uncommon to then take a break and see how would a wire like a Truma Gold wire would actually do, see how that does. And right now we see that the issue that we're getting into is this proximal cap. It felt like a rock.
Picture from.
And that's why it was so hard for the wire to actually make it down. But it seemed as if which is a good amount of brute force, be able to penetrate that proximal cap. And that was moving in the right direction. Now, the question is right now, Dr. Gershon, you have an 035 catheter, and at what point would you want to change that for an 018?
Probably very soon, as you know. And we're just going to get this down here as soon as we can. And if it pops in, we're lucky. If it doesn't.
Again, it's the same kind of technique that we know very well. It's kind of rotating this wire, slowly advancing it with your four fingers on the other side, and slowly making its progress all the way down. Looks like we're almost there.
Can we go back to roadmap on that other picture you just took?
Can we go back to roadmap on the other picture? Yeah, Ray?
Yeah, so for the technical team, our questions are frozen. We're not able to get any questions here for us. So
off this side.
I'm off to the side.
Off the side a little bit. Can we turn the screens so Dr.
Can you turn these screens to the side, please, so I can see?
We can get rid of both of the ultrasounds.
Okay, there's no questions. Okay.
Get rid of both the ultrasound machines.
So we have no questions. So we are now working from above again with that Confianza, trying to find another plane. I can't see where I am. Yeah, now I can. Okay. So now we are definitely in two different planes. Off roadmap?
Yeah.
Thank you, guys.
Thank you. And can I get another Confianza from below, please?
So just trying to work this wire slowly to try to get it into the system here. Okay. I think it's making that same turn again. Yep. Give me a little die here. So if we're going to fail from this way 2 or 3 times, we might have to do some sort of loop reentry technique to try to get in. And it is not quite there. Okay, now okay, give me a contrast now. Nope, it's going the same way.
Yeah.
Same way. So we're in that dissection plane that we created, which is making it more difficult for us to find a way in. Nope, again, the same problem here. Okay, that seems to be
better. Finding a new point of resistance usually means that you've actually made some progress towards the right direction.
So we're just going to give a 2 cc DSA here. Okay.
Second.
And like we said, we're going to have a lot of trouble here trying to get in. So we knew this is going to be difficult. This looks a lot better than that.
Yeah.
Let's see if we're lucky to pop in. Laura? Nope, same thing. Okay, it's not keeping me straight here. Yep. All right. So let's do Give me a stronger wire here, guys.
Get an Estado, please.
Let's give me an Estado 20. Let me see where we are below. Can I try it a little bit from below?
Yeah, for sure. You want the
Let
same
me just
command?
try a little bit from below. Hold on. So I'm just going to go here, pull this back. Okay. No, that's,
Going with the loop here.
hold on. No,
D.
let me see. Let me show my above now. Don't push yet. So what I'm going to try to do is to make sure that we are in the right area. If I'm right on what I think I'm right, I think that's going to be the thing. You can see the calcification there. Hold on a second. Let me just go LAO. Watch your knees. Okay. 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 DSA. Any? So we're just trying to see where it is because the anatomy is not good anatomy, right? So where does the AT take off? Where does everything take off? See, that looks pretty good to me.
Yeah.
So I'm pretty happy with that. I think we're pretty good with a high takeoff AT here. So we're going to go ahead and push this up. I'm going to let Roman push the catheter up. I'm going to try to hold this tight so it doesn't go up.
This is going to be very interesting here. So anatomically, what's happening is there's an occlusion past the origin of the AT. So once we cross, we still would not have crossed into the distal segment here. So Dr. Krishnan, I have a question for you. How would you address that after you cross? Would
Well,
you bother
I
going
think
for
all
the
we need
rest?
to get a straight line flow to the foot, right?
So you would take this and
Yeah,
yeah,
I'd probably just
I
take
agree.
this and see
I
how
agree.
it goes.
I agree.
You're not able to go any further. There it goes.
Inching,
Yeah,
inching.
beautiful. And you can see there's some calcium there. Looks like it's possibly heading in the right direction. I would stop there here. Yep. And now what I'm going to do is I'm going to try to lose my loop here, which again pushed me out of the wrong plane. You guys see that?
Yeah.
So now I'm going to come back
There we
in
are.
plane and then try to go up here.
Now it's
So now we need to go there if we can. So this is the point that I think you have to understand that this is like a push-pull technique that me and Roman are trying to do together. So he's pushing and I'm pulling the wire and it may go, may not
that's the
go.
cap right there.
That may be
we're
the cap.
seeing.
All right, so let's do a little roadmap for me. We're going to need a tougher wire here.
Yeah.
Give us a confianza here,
We
guys.
have a second one right over there.
So what the other important thing now to do is to go to a different view. So we're going to go to a different view. So we're going to go contralateral with the view to make sure that we're not dreaming, which we may be, and I'm not afraid to say we may be. So now we're going to do a DSA and then, probably embarrass ourselves, but that's okay. So we'll take a cine now. And that's kind of when you do these tough cases live, this is what happens. So it looks like we're not really embarrassing ourselves. I think we're going to be pretty good here. So we'll see how this goes. So now we're going to go ahead and get the confianza.
He's got insurance.
Okay, this is it. And a quick wire introducer, guys, if you can. And so what we're going to do is we're just going to go ahead. I'm going to have Ray roadmap this for me, just so I know which way we're going. And then we're going to go ahead and start. Now you can say, well, why did I choose a confianza? Well, I have an 014 system. I have an 014 support catheter. I'm below the knee here, with the system. And I think if I'm right, I may ask if next thing I may do is ask Roman to wire that vessel from above and then come down and try to meet me this way, which may be what may work finally. But let's see.
I like that idea.
We still have a lot of time. Obviously, Dr. Mehta has been kind enough to give us 2 hours. So we will go ahead and show you all the different techniques that we're going to have to do to make this work. I'm just very careful pushing the wire here because obviously it's a sharp wire. I don't want it to come out and create any damage. So, as the wire comes out, it's a long way, obviously. Where's the wire? Wow.
Not here yet.
It's not there yet. Okay. And he moved. Is he having any pain, Ray? Okay, there it goes.
All right.
There's the wire. Okay. So now I'm going to pull this back again. I'm going to try to redirect. So I'm in that collateral there. There we
That
go.
looks nice.
Oh, I'm on top of it.
There is some patient movement here.
Let's go some
There's a
off-road map.
LEO.
So why don't you put a wire on top from on top, Roman?
I agree.
Use that catheter
I agree.
and switch out that wire and maybe use a hydrophilic wire to get into that,
Let me get a command.
this thing. So now what we're going to do for the audience is because the patient is moving, but I want to give a lot of contrast. I want to have a target from above and below. the Dr. Sharma is going to come from above with a what is it called? A hydrophilic wire. Our choice here is going to be a command 14, and he's going to use this catheter, this device to torque into what we think is the high takeoff AT. He's going to have to make a better curve. So the wire got dinged up. So it's important because there's multiple variations of the anatomy below the knee. And one of the variations is where the anterior tibial artery or the posterior tibial artery can take off above the knee joint, and what we call is a high takeoff AT. And to me, this is what this looks like, because the AT from below, it was actually sliding very nicely, didn't make the normal turn. The turn towards the tibia did not do that. So from the fibula to the tibia, at the upper 1/3 of the tibia and the fibula, it should make a turn, and it did not make that turn. So now Dr. Sharma is gonna have to probably do some form of roadmap from above to find out the ostium and try to get into that AT, which will give me a target from below. So it's not easy. You might have to use some curved catheters or something to be able to help them, or maybe even go to a more steerable hydrophilic wire. But we will try our best to show you which way it goes.
Me a little puff from above.
Give a little, yep, do a roadmap from, yeah, just so you can have a roadmap, yep. So with the roadmap, hopefully you'll see the ostium and it may pop in, which is what I'm hoping it does. So, he's moving again. Move. Okay. Yeah, is there any way, guys, he cannot move, or is this going to be? Hold on a second. Let me do it now. Ready? Laura. So again, you can see here. We're going to see which is the AT. The AT is down below. So you got to come down, Roman, and then you see the AT takeoff below. Yep, right there. That's the AT takeoff. Good. So now he's going to put it there, Flora, for me, off roadmap. So you don't want to push this wire because you don't know where you're going. But remember, now we have two things. We have a catheter from below, and we have a wire from above. I would now probably switch from above to a micro catheter for him. So this way he doesn't put an 018 Trailblazer in here, Roman, and then you'll be able to inject and be able to direct the wire. So let's go. Let's make sure you're in the right one. So we're just going to give you a quick little Flora, roadmap, yep, and a quick little roadmap, Flora. Again, just a quick 2 cc injection. Yep, and he is in the right one. You could see. So now he's going to follow that all the way down to where my catheter is with this 018 Trailblazer to help him steer this wire. It's very hard to steer because of the iliac tortuosity.
018 Trailblazer.
Yep, we have one on the table.
Yeah.
So we picked an 018 Trailblazer. It's nothing but a support catheter for the coronary aficionados out there. It's a support catheter from I believe one of the companies, Medtronic, I believe. And so what we're going to do is we're going to use this to go in there, and we're going to pick an 018 wire so we can change wire catheter, so we can change to stiffer wires if we need to. So it's always one step ahead with the planning. And now Dr. Sharma is going to take this down. So in the meantime, I have my wire from below. Dr. Sharma has his wire from above. And we're just going to try to help each other to show which way we're going, So as he takes that down, we're just going to rail it for him.
Got it?
Yep, I got it. Go, Laura. So we're just going to take it all the way into the vessel. That's okay. Yep, Raman's got it now. So
there we go.
Yep, there you go. We're going to take it all the way into the vessel. It's a long route. So there it comes. So there's a catheter with a nice clean marker. So now pull the wire back and just push the catheter forward. Yeah. Okay. Yep. Stop there. Perfect. That's it. Let's see. That may be perfect. Now we're going to come off roadmap here. Now remember, for everybody at home, where's my support catheter?
Yes,
okay, good. So what I'm going to do now is just pull the wire back for Dr. Sharma. I'd like it to come from above, since from below we're not really working that well. So from above, I'm just going to do a quick roadmap. Actually, you don't need a roadmap. Just go without a roadmap. Let's see, Flora, we can see how this thing works.
Let's see.
So let's see. See, there it goes. Okay, so now take your Trailblazer down there.
Same cat we were.
Yeah, careful. Watch your Trailblazer. Okay, good. Now, guys, I don't want you to dissect. Let's go with a Confianza type wire. Put a torque on this. Put a Confianza type wire here. And now is when we're going to try to work from below and above, right? So this, it's not that Dr. Sharma and I were really bright that we're like, oh, we have a high takeoff AT from the beginning. We figured it out because we had the pedal access, right? So now, as Dr. Sharma can step on Flora for me, I'm just going to take this up for him, Flora.
Yeah.
There it comes, and then we'll see. Give him a torque. Well, let's see where this one goes. Okay. So above and below. Hopefully once something will cross. Looks like I'm not going to cross. I may or no, I did not. Go to another view here, Roman, for me. This, I look, I'm behind it. You can see here, I'm behind it. So at least we have an opportunity here. And don't worry if you're working with your partner, because the whole idea is you want to create planes for your partner to get through, right? So you can't make the occluded vessel worse. So he just has to be careful as he enters.
Are you in?
No, I don't think so. Go to another view. I'm probably behind it.
Yeah,
Yeah, I'm behind it. Yeah. I mean,
that's always nice when you manage to wire in.
yeah, well,
Yeah.
you will. There you go. Let's see you come down now.
You get torque on this? Please?
Yep, and get him a torquer.
Yeah.
So again, it's just slow, small movements to not get crazy with your heavy duty pushing. You've gotten to this perspective of where you are at, and you'd like to continue down, and you will eventually cross. I believe that with all my heart, but it could be wrong. So we haven't tried the other lesion yet, which we will if we have to. But I think at this stage, this looks very promising to the both of us. So we're just going to go forward with this wire. So remember a couple of things. Dr. Sharma has to make this bend here. Right? Keep coming. Let's see where it goes. So there's the bend. Now slow down. So I'm just going to pull this back for him, Flora. Okay. Keep coming down for me. Keep coming. So, okay. So it's make it point a little medially.
And again, it's always very hard with
It's very hard.
with iliac tortuosity.
So what I'm going to do is I'm going to start from below now. He's created a plane for me. So I'm going to try to come from below right there. Maybe a good plane. Okay. Now pull your catheter out a little bit. Wire. Let me see. Nope. I'm behind it again. Let's go to another view here, guys. Yeah, I know. We're just going to a view. We're not giving die. Can you push his leg medially, Liz, for me? Hold on. I'm sorry, sir, if this hurts a little. Laura, and turn the other way. Yeah, like that. Yeah. Why is it so dark? Can you guys remove the radiation shields for us a little bit? Hold on, let me just stay there, Roman. You created a nice plane there. So again, this is the most difficult part here, trying to figure out how to get in. And okay, there our wires are crossing, so that's a good sign. Now, what I'm going to do is I'm going to leave him there, and I'm just going to push my catheter up to that spot.
Right.
So hold on, let me just rail you. Hold on.
Yeah.
Go. So now we're giving him a target from below to get into where the catheters are almost touching, or the wires are almost touching. Okay, good. Okay, a little higher. Okay, now I'll pull my wire back. Now pull your wire back and try to redirect. Okay. Maybe your catheter is biasing you. Pull your catheter back and go more medial. Yep.
I really have no torqueability here.
Yeah, so let me work from below then.
Yeah.
So come back up for me. Yeah, let's see. Okay. Okay, give me a hydrophilic wire. Okay. Oh, there you go. I think we crossed. Off-road, go a little lateral for me to make sure. Laura?
The other question is, are you in?
Well, the question is now you need to pull your catheter back. Now let's see. No, I don't think I'm in. Okay, guys, give me a. Okay, see there, it looks like we're moving one another. So stay there now. So now you see the catheter, the wires are interacting. Yep, so in two different views. Right there. So
they're
move your
definitely
trailblazer down to the bottom where they cross, Roman. Move your trailblazer down more. Okay, stop there. Okay, that's it, stop there. Now let's go back to the other view now.
Pull my wire back.
Yep.
Good.
Now I'm going to try to come from below.
This should, once these catheters are in these occluded segments, you have such a small.
We just have a little bit of what is it called? Pull your wire catheter back now.
Definitely interacting. So it's deflecting, right?
Yeah, but I think I need a different wire. Give me a fielder, guys, here. There you go. Okay. Yep, we're in. Laura?
And sure.
So you can see now we're in the vessel.
Good.
So everybody at home saw the technique that Dr. Sharma and I used. So now what I'm just going to do is just pull this back.
Do it again.
So we're just going to externalize this wire, right?
Okay.
All right, Robert, coming up with the wire.
Good. All the way.
So I'm just going to keep coming. He's going to.
So we're just going from the distal to the AT.
Again, sometimes it's better to be lucky than good.
Yeah, but
and,
that's a very important technique because because like as we basically were
we have a question. Show us above, Roman. The arch. Go ahead, Liz. Read the question. Yes, we are going to do IVUS once we're through.
yeah.
And we're going to be able to do it as soon as we do a balloon angioplasty to see how subintimal we were or subadventitial we were. So Dr. Sharma is just watching the wire as it comes out of the body on the other side. There you go. So now we know we're in the sheath. And now he's just going to watch it just come out of the sheath.
You even show
The
it
moment
here.
it comes out of the sheath, he's just going to show me the sheath now so they can see it. Yeah. No, you can
Yeah.
just show it down here. Yeah. There you go. See, once it's out this dilator, he's just going to pull the other one out and he's just going to take it out. So now you can pull out your Trailblazer. Yep. Yes. Well, that would have been a great wire to use, but honestly. Oh, so the question is there a deflectable wire like the Pilot? So the answer is the Pilot is a fantastic wire that we could use, but we chose not to because I think at this stage we were so close with our dissection reentry techniques that we're okay. So now, yep. Well, that's essentially what we did. So is there any role of dissection reentry is the question. And essentially that's what we did. So what I'm going to do is I'm just going to create this lumen here by pushing this catheter forward if I can, but it doesn't look like it wants to go. There it goes.
Yeah.
So the catheter is now through and through. So we are through and through now below and above. Let me just give it a little bit more of a push. So essentially for the audience at home, that is what we did. We did dissection reentry. We were very careful. Now we're through. So now you can pull the wire. I mean, Raman, you can pull the catheter out. Actually, before that,
why don't you pull more from
actually,
that
yeah,
side?
Ray, you pull from above, from
Pull
below,
your side.
from above. So this is an important technique for at home. So Dr. Sharma and I are holding the catheter here. And what we're doing is we're preventing shearing of the vessel. So I'm just going to watch the wire here as you pull.
Wait for 1 second. Hold on.
Yep.
I'm out. I'm going to
I
pull.
would just take it out. Yeah.
Pull mine out. Okay.
Yep. Here we go.
Because you don't want to lose wire at this point.
Yep. So now what we're going to do is put a forceps at this end here. So I don't shear the vessel. I'm going to feed it to my end.
Wait, time out. Sorry.
I'm just going to feed it to him here.
Don't want to lose
Yep.
the
Go
vessel.
ahead, pull.
Good.
So as he's
Got that?
pulling, I'm just feeding it to him. And I don't have to be on fluoro, so I can save my hands from radiation. So now all we have is a small little 0.4 diameter hole here in the foot, which I'm just going to allow it to bleed as we externalize this wire. So now that we've externalized this wire, we've got through and through what we call is the safari technique. So now it's through and through. So now we're going to load an 0.14 balloon from above. So give us an 0.14 20 long Armada.
You want to change it to a Spartacore first over this?
Yeah, you could if you can get it in. You think it'll go in?
Yeah, can I have scissors, please?
Yeah, it's going to be tough because we have a wire that's pretty thin. So now the options are what Dr. Sharma is saying is we're going to switch over and replace the wire with a very stiff wire with a lot of support. Something called the Spartacore wire. The Spartacore wire was a renal wire that was invented for renal angioplasty back in the archaic days when we used to do renal angioplasty, which unfortunately has fallen out of favor. But so it's a stiff wire is able to develop to deliver systems of some considerable bulk to the area. Here we're going from up and around all the way down to the foot. So therefore you have a very hostile iliac in this particular case. So we're definitely going to need a wire that has a lot of support. So we're now taking our 0.14 what is it called, teleport catheter, and we're loading the wire from above. And Dr. Sharma is going to take it all the way down to that distal area where we accessed to be able to go ahead and then switch for a Spartacore wire and then work from above. So one of the advantages and disadvantages of this technique, being through and through a lot of my colleagues and our colleagues with a balloon angioplasty did, because we have a wire support and we can create what's called as like sort of a coat hanger. The coat hanger will allow us to do whatever we need to do to be able to get in. So you can see here, the wire is not out yet. So the important thing here is to keep the system straight. And if the system is straight, the wire will eventually come out. Are you having resistance?
Just no.
Well, then it may be bunching up in the body. That's why. So, oh, the wire's out. Okay, good. Okay, now we got it.
Baby steps.
Yeah, baby steps.
Now,
So
just go,
now we're
can
going to
you
put a
show me
forcep
the,
here,
you show me the,
and we have a
the-
forcep here, and we're just going to watch this go down.
Yeah.
You can
Again, so
see.
once you have, if you can show this on the
Yep,
screen,
we
you
show this
see
down here,
you have
guys. We have
forceps at the distal end of the wire, outside of the body, and forceps on the other side. You've essentially created a,
coat hanger.
yeah, and you can have nearly infinite pressure.
So
So
I can-
crossing
I can
makes,
pull and my NP can pull, Ray can pull as well. You can see Dr. Sharma is having no problem crossing at all. So we're going to take it down to a little bit
where is
above.
my, I can see it. I see.
Yeah, but that's enough. That's you're going to come out the body there. Yeah, that's good.
Good.
I think you're plenty. Let's just
Yeah,
check
good.
our position with the DSA from above. Watch your knee. Yes, please. Yes.
Yeah.
I'm so sorry I missed that. What did you say?
One more time. Yeah, nice. All right, so just to read that out one more time, it's a lot of words. Is using the laser contraindicated with a dissection reentry, as a dissection may worsen to a perforation? That's an interesting question. I think,
Go for it.
Dr. Krishna, if you disagree, tell me. I mean, I think that in the case
Okay,
of
stop.
crossing like this,
One more
you know,
picture.
whenever you have
What you missed.
a dissection, any kind of atherectomy, you have to be very, very careful as far as which one you end up choosing, right? It depends on which one you end up choosing. I think, you know, as far as ones that you definitely don't want to do once you have a dissection reentry, one of them is 100% it will be some form of orbital atherectomy, even rotational atherectomy here. The laser in and of itself, depending on it's a case by case basis. It depends on what you see with your wire, because if you're crossing, if you're crossing from either way, and you see that your wire was still pretty close to the lumen, it never took really long ways outside of the body or outside of what looks like to be the actual vessel, you may be okay to use laser. I will argue that is laser even a necessary atherectomy device in this case? And I don't know if I would go for laser in a case like this. But outside of it, I think, again, just it's a case by case basis. It depends on what you're really seeing as you are crossing into the into the
So I
vessel.
think the question is a great question. I think that any sort of atherectomy, like Dr. Sharma said, has its complications because of the fact probably laser, if you do dissection entry, is okay. I think orbital or rotational may be contraindicated. Directional is okay if you're experienced with it. But I think definitely you need to really understand the morphology, and that's where IVUS is going to come in.
Yeah.
If the IVUS shows you that your dissection is not too bad, then you can do either laser or
Yeah.
directional. So now what we're doing is we're going to change this out. Yes. No, in this case, we used Angiomax because we anticipated a long case. Angiomax has safety data and PAD, and the safety data in PAD is quite impressive, that it's very safe. It does not have efficacy data. So in these kind of long cases, we go ahead and use bivalirudin, no longer called Angiomax, but that was the company that made it one back in the day. So now this is bivalirudin on today's day and age. So yes, we use bival. So you can see now we're across. We're just going to put it deep in the foot.
The goal is to also make sure you go past where you had access in case you have to any further.
That's fine. I mean, yeah, you just
Yeah.
got to make a point the other way if you can go into the main vessel. So we're just trying to. It's very tough to torque from above, as Dr. Sharma said, because of the tortuosity.
You can get torque around
Get a
this.
torque around this, but we'd like to get it deep into the foot if we can. So since it's bleeding, we're just going to go ahead and now put it
Another
deep
one.
in the foot. Okay, what's the question? Well, I'm not one to tell you what so it's someone who's just started doing peripheral intervention should try to do this kind of case. I think if your comfort level and your skill level is good, you need to understand the anatomy.
Yeah.
A lot of people would have gotten fooled that this is not the dorsalis pedis or the anterior tibial artery. I could just leave it there for now.
Yeah.
The dorsalis pedis or the anterior tibial artery. But obviously, knowing the anatomy and understanding what it is, we said let's do a high takeoff. Probably is a high takeoff
that's
AT.
good.
If you notice, I did not realize that it was a high takeoff AT on the angiogram, and neither did Dr. Sharma. We know that's fine. We know there's obviously a entity that exists such as that, but at the same time, we also know that you can't just predict that just by looking at it. So having the wire from below clearly helped us. So those are the skills that you need to develop. You need to develop skills of ultrasound guided access. You need to develop skills of dissection reentry. You need, I got it, brother. You need to develop skills of the other
Dual
one
balloon?
is the double balloon and the
Dual balloon.
what is it
Never
called?
mind, we have it.
Cart and reverse cart
Yeah.
techniques.
And I think
Those are other techniques
yeah.
that you need to have to attempt something like this. But obviously, this takes a little bit of time
Yeah.
to develop.
Again, like no one, people rarely work in isolation. You always have colleagues who work with you. You'll have people who've done this with some degree of more experience. You also have vascular surgery backup, and it's important to not be shy to ask for help. It's kind of a part of the learning process. No one walks out of fellowship. I got wire.
Not yet, bro.
Okay. No one walks out of fellowship able to do super complex cases. It's not to say that there's a learning curve, but there is just learning that happens as you do more and more of these cases. And this is arguably, very, very challenging for a number of reasons. It's a CTO, it's a short lesion, but a very ambiguous lesion. It's a Rutherford 5 patient, so already we know that there's increased risk of mortality just with the patients, how they actually how they present. And the fact that the amount of work we need to do to cross from both above and below, to know the concepts of wire externalization and the Safari technique. Show me the 15. And then honestly, we didn't spend that much time on air showing the. I think we're stuck here.
You are
showing.
No,
showing the difficulty with the iliac arch, but that for some, in some cases, may be one of the biggest limiting factors. Just that in and of itself.
But why don't we just balloon this?
Further,
oh boy, it's a real long balloon. See, this is what I was talking about. If you had through access, you're able to pull this balloon through for sure. But now you have to be careful so you don't lose the wire.
Showing the iliacs.
The iliac. Oh, sorry. Yeah. The other thing is, as Dr. Sharma was pushing, you have to make sure you didn't push the sheet back in the iliac. I doubt it because there was a lot of friction, but anything can happen. It's always good to go back and check. And maybe it did move back. And the answer is it did move back. So this is a major issue. I'm glad it happened here so we can show you how to deal with it. So what you want to do here is now slowly pull the sheet down. You don't want to push. You want to just pull it, fix your balloon and pull the sheet down. So the balloon is going to act as your catheter and the sheet will go forward slowly.
It's very important
Right.
to look at the distal edge of the sheath. It's right at that turn. So you want to be very, very careful as you're going down because you don't want it to aggressively make a turn.
I think that's enough.
Yeah, I think this is.
So what we're going to do is we're going to balloon the track.
Yeah.
Look, it's an undersized balloon, obviously. We're going to balloon the track here. Okay. And we need to straighten out the balloon. Pull the balloon back a little, guys. I mean, pull the balloon, just pull it so it doesn't bend like that.
Yeah.
I mean, up here, you see this?
Yeah.
Okay, that's good. Perfect. Now you can go up with the balloon.
How long was this one?
200.
Oh, good.
So we're going to
Even
balloon this.
longer.
We're going to just balloon the track to get it going. So you can see the balloon goes up now. So we're just going to go to nominal. Let me show them the inflation.
can focus. If you see, there was not anymore. It's still a little ring around 15, 16 where that CTO was.
Right. So we're going to leave this up a little bit. I know we're ballooning this area, but it's an undersized balloon, so I'm okay. Let's go down and then pull back and get a little speed.
A little wire here. Good. Good.
Get a little speed and now go.
All right. Beautiful. There we are.
Okay. Don't hesitate to balloon again. Don't push the sheet back. Just balloon it. I would just balloon it quickly. Just balloon the track. Yeah. So the sheet doesn't go back. You don't want the sheet to keep going back.
Up again.
So we're just ballooning now, creating our track before we IVUS. You can see there's another lesion, a very tight lesion, the occluded segment, another lesion. And again, we are now able to hopefully crack this one. Is that a
Nominal.
you don't think it's a lesion or air?
That looks like a lesion.
Yeah, go up a little more.
Yeah.
At 10.
There you
There we are. Very good.
There you
And as you still see a little napkin ring there.
go. Yeah, go up again.
All right.
12.
Yeah.
At 12.
Just do the shuffle, do the Dr. Sharma shuffle. There
Right,
you
just-
go. There you
Up and
go.
down.
It's a little
Slowly.
bit of a lesion.
Yeah. But we know we're not done yet as
So
far
down,
as
and then we
the
can go further
intervention,
down.
right? So as we pin the wire, we've opened up more and more of this track. We're going to get a different part of the balloon to where this lesion was. So you can pull back a little bit, gain some
Get some
momentum
speed.
again.
Yep.
Good.
Now
Pin the
go.
wire again. Right. And we're going to go. And there we are. Now we're all
now
the way
you can
down.
go up. Now you go up
Yeah,
aggressively.
let's go up again.
And now you can see the end of the balloon is right there.
Yeah.
Now we're creating the whole track for us. And there's our lesion. It's still there. What are you at now? Wow. That's a really tight lesion.
We do a coronary sitting on that,
There it
please?
is.
Did it just pop?
Mhm.
Yeah.
It looked like it
Oh,
popped.
yeah, okay.
Yeah.
Sorry. I think it's time for some level of discussion here about basal too,
Yep.
that just came out.
Sure.
You know, I haven't had a chance to look at the supplementary materials, but I know we're always going to be talking about these
Yeah.
new studies
Yes, sir.
as they continue to come out.
Right.
So basal 2 was looking at infrapopliteal venous surgical bypass versus best endovascular therapy. Now, it showed something a little bit contradictory compared to best CLI.
So one technical thing, you're not going to come out of the body in case you perped. You're going to stop there. So we're just going to take a quick DSA here. And hopefully we'll have good feelings after this one. And there's your good feelings. So there's your high takeoff AT into a DP, right?
Mm-hmm.
So now we're going to go ahead down to the lower.
Interesting. I would like to look at this. Are you bleeding more now? No, you're not.
Well, sometimes it does, sometimes it doesn't, right? So let me just move this. I'm sorry, sir. There you go. So we're just going to go ahead and do another quick picture. And then we'll go ahead and do an IVUS. Go ahead, Roman. As you talk about basal 2, I'll do the IVUS.
I think it's it's the question always comes down for us. A little perp? No, good.
That's
okay. Good. Yeah,
yep.
Wonderful.
Okay, you go ahead.
Yeah. So as we're the CLTI group has always been the most plagued with the worst outcomes, and the question has always been, what would you do for a patient of yours where you have, as the literature is slowly expanding, we're getting more and more good, robust data. What do you do now where you have in a period of only 6 months, almost 3 trials that have such conflicting evidence? Best CLI first, and we have Revive saying almost the exact opposite. Now basal saying it. And I think, if I was to kind of sum it up, I think the difference is simply that the difference is in what we call best endovascular therapy. And I think it's what we saw in best CLI. It's arguable that perhaps, although we did see once again that the venous grafts did very, very well, the question is, what is best endovascular therapy? And I think that's it's not one that is so clear here, even in the meta-analysis review in a Revive, but that there's no difference. I think that really does kind of make some sense here when you're considering the paucity of data, and when you look at kind of where this whole road started back in the early 2000s and such, where the endovascular arm was simply just, Flora, was the endovascular arm was simply just PTA. It makes sense that back in the basal 1, watch out, you get a toe is stuck there. Good. Where basal comparing a venous bypass to PTA did better. That makes sense to me.
Okay, record. Show the IVUS as he talks and record.
A little bit further.
No, I'm in the definitely through.
Okay, good.
Yeah,
further down.
There you go.
Yeah, right. Okay, let's start pulling back. Good. Actually, you can see really nice here. The what we could not show you on the ultrasound. If you look closely on the left and right of the left and south of the screen, you see the veins next to the actual vessel here. But now now we're in this day and age where now we have new data. Best CLI was in large favor of a venous bypass in these CLI patients. But again, in those cases, less than a third of people got any drug-coated technology. We'll pause here for a second. I think we just if we can look at the IVUS, we saw that we've actually had a pretty nearly luminal cross. Yeah, which is actually pretty surprising considering the way that we went.
3, 4. So
1, 2, 3, 4. Yeah, it's the 4 millimeters here
up top. So we should get us. Do we have a 2530 210 guys?
I'm going 3035.
Let's start with the 2530 and then go to 3035.
Yes, try to keep it low.
No, honestly, it's true. So we try to do as much as we can. Obviously, there are times we do get irradiated. Most of the time we have our our protection here, and we try to use inserts in the legs. Obviously, this gentleman having CLI, we did not do that. The other thing is we also wanted to tell you about the low Philips systems and other systems. I'm sure have the same thing, which have a system which will reduce radiation, but what we call is low fluoro for peripheral vascular disease, which we also use here. We do switch to coronaries, as sometimes you hear myself and Dr. Sharma saying, switch to coronary mode so that we can see, because sometimes you can't see that. Others have done it, but that's fine. Give us a long 2.5 balloon. And then others have also done what's called as pulse fluoro with the EP, but again, it's very difficult to see. So yeah, radiation is part of it. Radiation safety, we take it very, very seriously. And therefore, yes, to answer your question, it's very important. Well, the first thing I want to just to answer with that is when the patient is a Rutherford 5 means they have tissue loss. If they have tissue loss, there's pharmacotherapy other than good wound care is not going to really make a difference at this stage. However, the mortality here becomes a limb salvage situation. But your question is very important because it does not take away from the fact that the mortality of this patient is also looked at. So this patient currently, as Dr. Jaffer so nicely said in his presentation, is on what we call as guideline-directed medical therapy. He's on a statin, he's on an aspirin, he's on an ACE inhibitor, and obviously he's also on this gentleman, because we knew we were doing this, was also put on an antiplatelet, the clopidogrel. So yes, the question is, does Xarelto fit into that, or rivaroxaban? The answer is, at this stage, take Flora further for me, brother. At this stage, I think that it's not in the guidelines, but I think in select group of patients which follow the COMPASS, what is it called?
The Voyager PAD.
Voyager PAD protocol, then I think, or criteria, I think it should be reasonable.
All right.
Go ahead, go up.
You have a couple of more questions here. So I think we'll skip that one because that's pretty much similar to the previous one. But now here's one. What are the most promising areas of research for improving our understanding and treatment of PAD, and what new developments can we expect in our near future? I think that does kind of allude to the previous discussion that we're having, is specifically what are the best outcomes that we have moving forward for this particular group of patients.
Yeah.
The CLTI group has been plagued with amputation rates, higher cardiovascular mortality, and death compared to all other Rutherford class patients. So that's why, as we were discussing, Basel 1, best CLI, Basel 2, Revive, where is the granularity really coming from here? And how do we make sense of this data that is conflicting? I think that's where there's going to be a big shift in the big paradigm shift as we move forward. As far as what we can finally understand is, we understand venous bypass grafts are excellent, but how do they compare with what universally people believe to be best endovascular therapy? But the problem is there's no universal definition of what best endovascular therapy is. That's where, and that's a point that I think we're trying to make here, that there really is no best practice. All we do know is that the previous devices that have been used in the previous trial, PTA alone, compare that to a venous bypass, it is obviously going to be worse. So there's no question about it. But now you have single arm data, of other drug-eluting technology, drug-eluting balloons, drug-eluting stents that are compared to PTA, and you have efficacy differences in patency at 1, 2, 3, 5 years that is better than PTA. So you know that there has been some improvement in that arm. So the question is, when you have these trials and you have limited percentage of your endovascular arm getting these technologies that have proven to have improved patency in both the claudication and CLI arms, what exactly is that gonna, how does that translate to your real world practice? And how do you really
I totally agree. I think that the jury's still out. And when you talk about best endovascular, I think they're talking about the endovascular treatment that has the most modern therapy or modern data. So, we know that below the knee, that's very limited. We know obviously drug-eluting stents, because of Destiny, Yukon, and Achilles, shows that DES works better than BMS. We know there's some conflicting data with DCB because obviously the Biotronic study failed, as well as did the Lutonix BTK study also. And now recently Saval with paclitaxel also has failed. But what we've learned from this is what Dr. Sharma said, is what is best endovascular therapy. First of all, our techniques have to be different. You notice in this particular balloon angioplasty, we left the balloon up for quite some time. We've been up for now about 3.5 minutes. We learned that because in the Saval data, even though the balloon angioplasty was so beautifully done, it was so beautifully done in a protocol-driven manner that the results showed that it was better than a drug-eluting stent. So therefore, I think that our technique of balloon angioplasty is to improve. Second thing, we also have further what we call a specialty balloon angioplasty balloons. In Saval, the balloon angioplasty arm showed a patency rate that was phenomenal. If you look at our SFA and our balloon angioplasty techniques in both impact, which is probably the study set that has the longest follow-up, at 1 year, the balloon angioplasties were probably the best ever recorded patency. So therefore, I think that our techniques have to get better. We have also now evolved to specialty balloons. The chocolate touch study or chocolate bar study showed below the knee with the chocolate balloon that there was a reduction in dissection rates, reduction in recoils. A nice study that talked about recoil below the knee as being the major cause of failure, which occurred basically 10 minutes after angioplasty, showed that you can't just do angioplasty and leave it. A prolonged angioplasty may reduce recoil. Again? And as our study in the DCB failure showed, that recoil seems to be the highest predictor of restenosis. So, I think our techniques have to get better. So what is best angioplasty or best endovascular therapy? I think the first thing is best technique, which balloon angioplasty. Second is use the data that you have available. So in this case, we know that we were down. We have a heavy plaque burden. We did a prolonged 5-minute balloon angioplasty, which is not long enough, by the way, but down. And now what we're going to do is we're going to do a directional atherectomy based on the definitive LE study, which showed below the knee that the directional atherectomy had a very, very good patency, double negative, had a very good patency but shorter lesions, obviously. Obviously, this lesion has never been studied in any clinical trial or registry. Show me below, show me the ankle. Any clinical trial or study. Okay, fantastic.
Yeah. So there were a couple other very good questions. There's a question about what are the major clinical trials to really pay attention to right now. I think the most important ones as far as the CLTI group will be Best CLI that was published about I think 6-7 months ago, followed by the Revive database that was published in JACC, and just 2 days ago Basel 2 was published. Again, all of these are looking at CLTI patients with comparing venous or some venous or prosthetic surgical bypass versus
what happened?
No flow. Try again. Versus endovascular therapy.
You did? You gave ACT?
Okay. Good. All right.
There's the flow.
Yeah.
Okay, good.
All right.
So
just lower volume.
Now we're just going to go ahead and do a quick atherectomy here to debulk it further, and then balloon angioplasty with a 3/0 long balloon. Give us a 3/0 long balloon, guys. So the technique of directional atherectomy below the knee is going to be very important. I think one is you just want to do one cut on one angle. Unfortunately, you just need to use your judgment on where we're going to go. And I felt that we should not point the cutter laterally here. We're going to point the cutter medially. And you saw in the IVUS, we were mostly intraluminal everywhere we went. So we're just going to go ahead and do one cut. And then the question becomes is how are you going to deal with that ostium? Do you want to DES it or not? And we'll decide. So Flora for me, my friend. So the technique of atherectomy in this particular case will be taking the atherectomy catheter, doddering it down, right? Which is what we're going to do right here. I'm not going to cut that angle right there because it's quite there's going to be a lot of bias. I'm going to dot it down to 30. And I'm going to pull back to the straight segment, a little bit lower. And then I'm going to torque, Ray, mag up on my cutting device, please. I want to show you the teeth of the directional atherectomy device.
All right.
Mag it up again, sir. More.
So as we get ready with the atherectomy, we have another very good question. Love the publicity here. Do we have a live symposium this year in New York? And if so, when is it? And the answer is absolutely yes. We have our next New York Endovascular Summit happening here again in Manhattan on September 22nd, 3rd, and 4th at the ETC venues. And really, it's a very multidisciplinary conference with both interventional cardiologists, interventional radiologists, vascular surgeons, and we even have a dedicated podiatry summit as well as a venous summit and aortic summit. really to spend 2 days with a number of live cases, multiple didactics,
Okay.
to really showcase kind of these very complex cases that are being done, and talk about the latest data and the newest emerging techniques. This is all going to be preceded with a fellows course on the 22nd, or sorry, that's actually going to be closing it.
Sure.
But there's going to be a fellows course as well, where we're going to be, having a set of didactic lectures, as well as hands-on, simulators for the EVARs, as well as other hands-on simulators for Supera deployment, ultrasound guided access, direct SFA access, and then even a dissection, a pure dissection lab to help even vascular surgeons practice their dissection techniques and identify the notable structures. So yes, we certainly do have one. The registration is open as well at NYSEVS.org or com, one of those two.
2, 3, 4. What's nominal, guys? 6. Go to 8. So now you see that we've now ballooned with a 3.0 balloon. And one of the major things was the sizing has been a big deal, because balloon angioplasty, that's also something we learned from Saval, that the sizing of the balloon really, really matters. So failed clinical trials can give us a lot of information. So you can see here that Saval showed us the technique of angioplasty, as well as the sizing, that it really matters. These are things we often suspected to be an issue, but we really haven't had a randomized trial study that's shown it. So right now, currently, what we've been able to do is, now we're going to leave this up for a quick 5 minutes, and I'm just going to quickly talk to Raman about the surveillance of this patient. So now that you've done an excellent job opening this vessel, the blood flow hopefully will be perfect to his foot. Wound care will be done properly. What is going to be our surveillance, and what's our rhythm for surveillance, and how often do you see the patient, and what are the signs and symptoms you look for failure?
Yeah. So obviously, having a pre-intervention, full, objective measurements of ABIs, arterial Dopplers, TBIs. In his case, I'm sure his ABIs were very low, and kind of having a baseline understanding of what his wound looked like. So go by the Wi-Fi classification, Wagner classification, and I get a very good understanding of what his symptoms were outside of just his ischemic ulcer. Post revascularization, the first thing afterwards will be to check again resting ABIs, about 2 to 4 weeks, and minimum of 4, I would say, as well as an arterial duplex. Whether or not, if you have somebody who has less renal insufficiency, it wouldn't be a bad idea, if you have the capabilities and your institution is really well set up enough like that, to at some point incorporate a CTA. I would not make that a first line a surveillance technique, but if it is available and it is one that is possible for you, then perhaps it would not be a bad idea. Definitely in the case of people who are also going to be getting a bypass graft. But the most important thing that you'll be seeing will be this wound, and seeing how the wound heals. Know what the pulses were to begin with, and then what they're going to be afterwards. Any sudden shift in velocities, any sudden shift in the PVR waveforms, or a drop in your ABIs, I think you'll be very remiss to not take that very seriously. And beginning initially in the first 1 month, as far as follow-up, and then from there spacing it out to maybe every for 1 month, 3 months, and then 6 months. By that time, you should expect significant healing of the wound, and then as needed follow-up after that.
Yeah, I think that was perfect. You hit on all the points that we need to do. You need to have a protocol in place, 1, 3, and 6 months, whatever it is, follow. You need to have frequent clinical follow-up. I think that's the key to, like you hit so nicely, is to figure out how the wound looks, and whether there's any further healing of the wound or deterioration of the wound. So I think those are the 2 most important things. So as you can see, we're doing prolonged balloon angioplasty. We're at 3 minutes. And so now what we're going to do is, actually we're at 4 minutes. I want to give it 5 minutes with a 3.0. And then I'm going to re-IVUS this, and then decide what we're going to do, whether we need to stent. So currently, like my practice, again, like Dr. Sharma said, we don't know what is best, endovascular therapy. My practice is to secure the inflow and secure the outflow. So the outflow here, it looks reasonably good at the level where we cross. But remember, the wire actually went all the way up, so it's really a proximal issue that probably took this down. So I'm going to be very, how can you say, not hesitant to stent the proximal occlusion, because I don't want this to go down in any way.
Agree.
And we know the drug-eluting stents do a great job. So what I'm going to do here is, Robin, could you talk a little bit? Actually, I'll just mention it. So one of the advantages we have at this stage is that right now we have 3 non-indicated drug-eluting stents for below the knee. We have 1 bioabsorbable stent that is under investigation, that we've just completed the trial, which I had the privilege of being part of, me and Dr. Sharma. And now the question is, obviously we're going to use off-label stents now. How do you think reabsorbable stents are going to change our ability to treat this lesion in the future, Raman?
Well, I'm hopeful that is going to be better than the coronary world.
Yes.
I think it is going to be a part of the new future. I think the idea of not leaving any metal behind is very sexy in the peripheral arterial disease world and the endovascular therapies. I think it's a nice idea to know that you can actually have a bioabsorbable scaffold that over time is going to be gone, but still have the component of drugs. I think that may be one of the few parts of the future of the below knee interventions as going to be very exciting, as well as that will be the below knee stents that will no longer be using paclitaxel as a Saval, and whether or not the limus option will really be a game changer in the tibial world. And I think I'm hopeful, if you think about in the coronary world, how when the drug changed, there was much better restenosis outcomes from the original stents. Now could we get a new IVUS on again, please?
And now this is post IVUS, and I'm really looking for any dissections that I need to tack up or anything like that. No mueva, senor. Okay, you can see here, there's a little dissection there. Oh, not really. I think it's more plaque versus little dissection. And then at this stage here, very nice. So you can see here, we have a very nice non-dissected segment. The only question is, do you cut out that dissected segment with a directional atherectomy? Do you stent it? Obviously, that's not a nice area. No te muevas, señor. That's not a nice area for stenting. But you can see the lumen is quite large here. It really has no issues in terms of any dissection except distally.
I think the area in question is
Going to be right around, probably right here.
Yeah.
Yep, from here on. So you can see there is a little bit of dissection there, but again, nothing significant. And then at the level of when we turn into the ostium, which is right here, that's where we're kind of going to have to stent, it looks like to me. ¿Qué pasa, señor? ¿Todo bien? Todo bien. Okay. So now I've decided we're going to stent the proximal. The only question is, what stent do you want to use for the proximal?
It seems like it's a pretty long lesion. So
let's do a DSA for distal.
48s will probably.
Yeah. So get us a 3.548, guys. Show me distal now. Oh, sorry.
You're good.
Laura. Okay, let's do it. Yep. Okay, inject. No mueva. No mueva. So it's right around 25 is where we saw it, or was it lower? I think it looks pretty good. I'm going to leave this.
Yeah, I think the question is higher up.
So I think we're going to go higher up here. And this is where now we're just going to do a quick roadmap.
Do you want to do a DSA? Take a good look.
Just do a DSA, yeah.
Yeah.
That's enough to say. Yep, that's it. No mueva. So you can see here as he comes down there, look at the flow right there. Actually, we got to go proximal.
Yeah, it's like 10 almost.
We got to go all the way to 10. All right, give us the 3.548, please.
That should get us mini 2.
What?
So we can get the actual CTO area too.
I think it should
Yeah,
reach, right? We have it. We have it. So now we're going to go with the coronary drug-eluting stent. And I'm not worried about crushing this area as much. I don't think it's going to be a big issue here.
Yeah.
So we will go proximally. They do really, really well.
And again, it's also really important, like as one of the previous questions about would you feel comfortable doing this as somebody as one of your first cases?
Real?
remember, it's also pretty important to realize that like when you decide to make a decision about stenting, remember, it's important to keep in mind that you're trying to make sure you don't burn a bridge. So that distal lesion that we were looking at but some question about.
I got resistance up top. So it's such a tortuous one that the stent is giving me.
Was that the
Okay,
proximal lesion?
maybe. No, I don't think so. Okay, it's the arch.
Yeah.
Okay, so we still have to take care of the proximal SFA.
Yeah.
So we're gonna stent this and move on. And
How long we are.
right, let's go.
Go ahead. A little
Mhm.
further.
A little further, you want me to go?
Yeah, I think so. Like 10
Yeah,
and down,
okay.
right?
I agree.
So what do we know, right?
Right there?
Maximal medical therapy. I like that.
I like that. Go up.
Maximal medical therapy. What does that include? I would say first and foremost, risk factor modification. So smokers need to stop smoking. You need to make sure, stay still, my friend.
What are you at? 12, 14?
Smokers need to stop smoking.
Go up.
Diabetics need to be on insulin, metformin, whatever they
Yeah.
need based off what their A1Cs are. Statin medications. This is one of the most atrocious things we see, that even in these randomized controlled trials, there are some of the populations that are seen have the number of patients or percentage of patients on statins is somewhat as low as 20%.
Yeah.
Basel was showing something was very, very nice. And the fact that the medical therapy, 80% of the patients were on statins, which is one of the highest.
Basel 2, you mean?
Basel 2, sorry. Basel 2 is showing that there's 80% of patients were on a statin, which is not something that you see very, very commonly, but it's nice to see. And then the question comes down to, what is your antithrombotic, anticoagulant strategy? Voyager PAD was the one that had showed the best outcomes post endovascular revascularization.
Nice.
You want better? No, I think that's sufficient.
Let's do another quick IVUS.
Yeah.
So we treat the coronaries, the peripheral, when we use drug-eluting stents like the coronaries. We know in the coronaries that stent apposition is very important. We know stent sizing is very important. And we also know that, so therefore, why not use the IVUS to make sure the stent is opposed, which is what we're going to quickly do. So those are all good points. To answer your question, to prevent this from reblocking, we don't know what the optimal therapy is. And I think Dr. Sharma, hit that on the head. What we've tried to show is techniques of balloon angioplasty that we know have been validated in a randomized controls trial. We've shown that we've used a device, directional atherectomy. This is the IVUS, right?
Mm-hmm.
We've shown that directional atherectomy, with some data shows that it may be effective below the knee. And so now we're showing that IVUS, at least extrapolating the coronary data, when IVUS intervention may obviously improves outcomes in the coronaries, will hopefully improve outcomes here. So now probably our IVUS has seen better days, and we're probably going to, there we go. We just got connected.
So can we this time please decrease the diameter?
So now we're just going to go distal. Okay, ready, guys? Record. My whole thing here is just so that I want to make sure my stent is opposed. No te muevas, señor. So I just want to make sure my stent is opposed. And it certainly looks opposed there.
Yeah.
There.
Well sized.
A little worried about proximal. That's why I wanted to do this, just to make sure that there's no IVUS issues that would help me want to post dilate this. We did go quite high. And it looks like there's plaque, but it looks like it's opposed. But now at this stage that we're done with this, now what are we going to do with the proximal SFA, my friend? What do you want to do with that focal lesion? So let's go to that angiogram, Osman, the initial angiogram. So let's look at the whole SFA to make sure we don't leave something. I think it's the next one. So we have some calcified plaque distally, right? Proximally, we seem to have the only really hemodynamically significant lesion. You could see here. Right there, that area. Then next. So in this area, right above the pop, I don't remember seeing anything. Not much. See? Yeah. So I think the issue here is a focal SFA that, because it's a CLTI patient, we want to treat. Yeah. So I'm going to just survey Raman and Osman here and ask them both, since Osman is just about to graduate. First, Osman, if this is your patient, what therapy are you going to do there?
I would do the Xarelto 2.5.
No, I'm talking about for the approximate
Oh, sorry.
lesion.
I agree with you on that one.
I think definitely I would. It's pretty calcified, so I think you
Well,
can.
no, the proximal lesion wasn't that or was it calcified?
No,
Yes,
right
it
here.
was calcified.
Yeah,
Yes.
yeah.
I think it's reasonable to shockwave here, and then I would you know, I would consider stenting it if, you know, especially if there's a lot of recoil or and considering his case presentation.
Right. Okay. Raman, yourself.
Yeah. I thinking about everything in conjunction. Remember, we've also done a lot of work. We've done a lot of this CKD, which we're trying to limit the amount of contrast we're going to do for the remainder of the case. I'll try to keep it as simple as possible. I like the idea of IVL. The overall cost of the entire case are also something you also have to kind of keep it in the back of your mind. If that's not an issue, I like the idea of IVL. I'm not sure how necessary it really is here. I think just a PTA and a short drug-eluting stent will probably do just enough because it's such a short focal lesion.
Yeah.
I don't think you need that much vessel prep, to be honest. I think just say Zilver and just a post dilate. But I will go 7-0 here for sure.
Well, I think we have an IVUS, so we can always use it. So let's get the IVUS
one more time.
One more time. So let's go over the data as we talked about. So IVL has registry data with the Disrupt series of what is it called, studies that show that IVL obviously works and has extremely safe and has some patency data that's not really compared to much. But when you look at Zilver PTX, obviously this particular lesion was studied in the Zilver randomized controlled trial, again, showed superiority balloon angioplasty. Obviously the impact database, the StellarX database, as well as the not database, the studies, both the impact 5-year, our StellarX study, Illuminate, which I was along with my co-PI Sean Leiden. We did that study with a lot of investigators who helped us so much. Again, showed that it was efficacious in these type of lesions. And then obviously Lutonix also with Kenny and his group also showed incredible patency as well. But the calcium has been studied multiple times, and calcium in different classifications, whether it's the PAX classification or our classification.
And that's it.
That's it. All right, time for a new IVUS catheter. So the PAX classification or the definitive calcium classification both showed that. Oh, it's working. There it is.
Oh, good. Never mind.
Okay, never mind, Flora. So what we're going to do is we're just going to go ahead and do a quick IVUS here. Okay, guys, record.
Looks like there's a good amount of calcium.
Okay, so we're distal. So we're coming back to the lesion. This is the calcium. It's again, it's not really luminally obstructive. No. And then I think it was, and now you can see it's just
14,
a calcified lesion. And now you see it's mostly soft plaque.
Yeah.
And then there's the lesion right there.
Yeah.
There is the tightest lesion.
Yeah.
So what's the vessel size there?
1, 2, 3, 4, 5, 6, 7 on the nose.
7 millimeter lesion. So you have randomized control data studying this lesion. So and also obviously you have the Boston Scientific study also showing it beautifully, showing that the drug-coated stent from Boston, what was it again? I always forget the name. The Boston Scientific stent. Illuvia. It also shows that it was superior to Zilver PTX at 1 year. So in this particular short lesion, I'm going to go with a drug-eluting stent. And what is the lesion length going to be? Flora, roadmap this now. So we're going to roadmap this.
Perfect timing. It's a very unique skill that patients have.
Señor, no mueva. Por favor.
Okay.
Gracias.
Well, it's up. Okay.
So I just want to use a little bit harder hearing. So we just want to make sure you can. So it's just you want to cover like maybe a 40 is more than enough, Chief.
Yeah.
Just from 9 to say 13.
14.
Yeah.
10 down.
What do you say? So Ray, could you grab us a 6.0 balloon Dorado, 6.040 Dorado?
I think we're talked about almost everything endovascular today.
Yeah.
What else?
No, it's great. I mean, we're hitting all the things very nicely. So we're using a high pressure balloon called a 6.040 Dorado by Bard. It's a Kevlar balloon, or BD, I should say now. It's a Kevlar balloon. And now we're going to go ahead and expand this. And we're just going to make sure that that the vessel prep for this is going to be good so the silver expands properly. So we're going to take this down.
I think although now that we're not talking about the tibials anymore, I think it's a good point to talk about, we briefly spoke about your specialty balloons that could be used, especially in the tibials. I think we would be remiss to not mention the newest kid on the block, the Serenader, which is made by Cajun, right?
Or, yeah, Cajun,
yeah. Yeah, you're on.
Uh-huh.
And how long is this?
It's 40.
Good.
Yeah, right there.
Yeah,
Perfect.
I like that.
So
And it has, almost like these little ridges, almost like shaped like a serenaded, like a serrated, yeah, a little bit in, yeah, a little like a serrated knife. Basically, as it expands,
so you can see the expansion here.
yeah. So you still see that little neck.
Bracket.
Good. So there it is.
Yep. Go to 12, please. 14. So another good thing to do when you angioplasty is go to different rotations, Laura, to make sure that the balloon is expanded on all sides, that you don't have differential expansion, and you don't. So you want to use a 60 then? Or you just want to leave this? I think this is good, right? Yeah, give us a 7040. 60. What about silver? We don't have it.
What are the where the sevens there?
And in silver, you have a 660? 640? Yeah, I think give it a 640.
Yeah.
I'll be fine. 640 down. Thank you. Oh,
you had those.
yeah, and silver. We we're going to use silver. Yeah.
And again, it also just comes down to what's in your closet, as far as the decision-making algorithms that you have, to
640, 660, no 7.
Okay, I have some really nice suits in my closet.
Yep. Roadmap.
So again, if I think, especially even in the scenario where, especially we're working in a private practice and you're going to begin one, you want to make sure that you try to choose your atherectomy devices, your specialty devices, and your stents as best as you possibly can, because you want to try to, or should we go
14 is
longer?
Good. No, 14. Yep.
Over the flat.
I think just cover it. All right. It'll be okay.
Yeah. Just make sure that you're not getting overwhelming costs by keeping a very stocked device closet. Try to use devices that can maybe cross both the femoral and popliteal system and so on and so forth. We are very fortunate in the sense that we have nearly every device that, or in stent and balloon, that you could ask for. So we have a lot more decision-making choices than a lot of other people out there. Sorry.
So we're just going to take this down and come back a little. Right there. Perfect. There you go. So that's where we're going to deploy this. Excellent. Get us a 70 balloon, please.
And choose that for a OD5R.
Mm-hmm. Should have done it.
Yeah.
But the balloon will do it.
Yeah. Okay. Nice little trade for the road. If you find that you delivered a long stent, and then your next planned step is to do a balloon angioplasty afterwards.
Balloon.
Oh, good. Never mind.
No, 35.
Yeah.
What is it? 20? That's fine. 20 is fine. 40 is fine.
Yeah.
So now what we're going to do is we're just going to change out the 035 wire through this balloon.
Yeah.
This way it'll help us walk the sheath out. And then we'll, before we do that, we'll take final pictures. We've got about 10 minutes to 15 minutes left. And then we'll be able to close up just look at nominal rate for me, and we'll be able to close up. So don't leave this proximal lesion, just because you've done the rest, because your patency depends on your inflow and your outflow. So your inflow has to be good as well. And this was clearly a significant lesion. So as we go forward, and you can see here, there's our 40 balloon. Yep, let's go up. And we're going to go ahead and just dilate this to nominal just to, yep. And then get us an 035 super core, guys. Thank you.
Beautiful.
Perfect. Excellent. Okay, down. So once that's done, now we're just going to replace it, the super core now.
Take this wire entirely out. All right.
The super core is going to go in, and then we're going to do a as we walk the balloon out, we'll keep the super core in the SFA, not to go all the way to the pop. And then we'll go ahead and do our final pictures. So I hope you've enjoyed this case. I mean, we showed you pedal access. I wish we could have showed you the actual ultrasound. We will next time walk this out. And then now we're going to just go ahead and do some quick runoffs to be able to show you everything. Okay. So guys, tell them, Flora.
Okay.
Tell them not to move, please, Flora.
Gonna do a DSA or?
Yeah, DSA.
Yeah.
Okay. Just enough to see, guys. Cindy? Okay, that looks pretty good. All right, since the guy's moving, we're gonna go look at the below knee now. Laura?
And remember, it's also important if you look at where all that calcium was, what we were looking at the shadowing at about 15 up on the previous picture. The calcium adventitiously that we saw in the IVUS does not correlate to any luminal obstruction, so it's safe to leave that
Laura?
alone. Yep, you're on.
Laura
Yep.
again? I'm just setting it up.
Oh, okay.
Okay, Cindy? No mueva. Cindy? We're just, no mueva, por favor, señor.
Perfect timing. No. Okay. Try one
Does
more
it go
time.
down? Cindy again?
Go.
Good. That's beautiful.
Really is wonderful.
Little dissection there, but I'm not too worried about it. Timmy 3 or 4.5 flow, whatever you want to call it. And now we're just gonna look at the foot now, go all the way down to the foot. And let's go low mag here. And just open this up a little bit. All right.
Maybe more cranial.
Okay. Okay. Cindy? So you got great robust flow into the foot. Of course, he's constantly moving. So I don't know how else to make it look better here, but I don't want to give him too much dye either, Flora. Hold on. Hold on. Okay, inject. Okay, actually, yeah, Cindy. Now, Cindy.
Don't move, buddy.
Okay, so there's
that
the
certainly
flow.
answered the question. Yeah.
See that, we're going to give nipride and everything. We're not going to put him into renal failure because of this. So I think we're going to stop here with 15 minutes left. I mean, if you want, we can show you a per close, or what are we going to do for closure here? Anything? You want to show them a per close live? This way they can see a per close, just to kind of show. Tell me about your closure device for this, Raman. What do you do for closure devices in PAD? Do you put them in? Do you not put them in? What is your choice of closure device?
It really always comes down to what the access site looked like. So I think it's a good time to go over that. Now that the wire is back. Good. Okay. So let's see what the access looked like. This one I would probably leave, to be honest.
Yeah, I think we're going to do manual. You can see you have eccentric calcium in that spot. So there's not a real good closure kind of situation. So we're going to leave this. We're very careful on who we close. Obviously, this particular one is not something we're going to close.
Yeah.
So we're going to go ahead and use a 7 short sheet. And I hope this has been helpful. Dr. Sharma and I thank you for logging in. It was a pleasure to see you in New York. And of course, we thank our team and the entire AV team for helping us get through this. So we will see you guys on next Wednesday back in New York. At that time, Dr. Sharma and I will sit it out, and Dr. Kapoor and Dr. Guja will take that case and we'll run it for you. So thank you again for your attention. Thank you.
Thank you very much.
All right.
You're clear. Thank you very much, guys. Have a great rest of your weekend.
Yeah.
Whatever.
Yeah. Are we mute?
Yeah, we're mute.